And whatever that screen is that you're working behind is a little place to put the LD numbers.
Yes, that's going to be all set for later today.
Wasn't that incredibly inarticulate when I asked you to do that before?
I certainly did not track at first, but we got there. We got there.
You got there. Yeah, we've had a request to add the LD numbers related to Health and Human Services as we consider them. So Karen's going to give that a try for us this afternoon. Good morning, everyone, and welcome to this session of the Joint Standing Committee on Health and Human Services. We'll be starting off with an information session. The work session will be this afternoon starting at 1:00. You can watch the proceedings on our YouTube channel by going to the legislative website and using the drop down to click on HHS. When you get there, it gives you the opportunity to click on YouTube channel. And that will be a place to see today's proceedings live or anything that you've missed, because everything's recorded and available on the YouTube channel. We invariably have technical issues, either on our end or on the others as they participate. So be patient with us as we work those things out. Committee's been really good about keeping phones off and things like that. So that's good. We will begin with introductions. So let's start with Representative Zager.
Thank you, Mr. Chair. Good morning, everyone. Right on cue, my phone went off as you were making that remark. Sam Zager, I'm honored to represent District 41 in Portland.
Representative Lemlin.
Good morning, everyone. My name is Michael Lemlin. I represent House District 88, Chelsea, Jefferson, Whitefield, and half of Noblesboro.
Senator Baldacci.
Morning, I'm Joe Baldacci. I represent the city of Bangor and the town of Hermon in Senate District 9. And I have my University of Maine Black Bear shirt on in celebration of all the great University of Maine athletes that are at the Olympics this year. Thank you.
Representative Perry.
Good morning. I'm Representative Ann Perry. I represent House District 140, which includes the communities of Indian Township, Baileyville, Barron, Callis, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
Representative Griffin.
Good morning, everyone. My name is Abigail Griffin. I represent House District 102, which is Clumber, Levant, and Cadescate.
Representative Craven.
Thank you, Mr. Chair. Good morning. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Madigan.
Good morning. I'm Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
Senator Moore.
Good morning. I'm Marianne Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative Meyer.
Thank you, Mr. Chair. Good morning, everyone. I'm Representative Michelle Meyer, serving Southern Maine's House District 2, which is all of Elliott and parts of Kittery and South Berwick.
And I'm Ned Claxton. Good morning and welcome. I serve Senate District 20, which consists of Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. So let's meet the staff that makes this all possible. So we'll start with Anna.
Hi, I'm Anna Broom. I'm one of the legislative analysts for this committee, and I work in the Nonpartisan Office of Policy and Legal Analysis.
And Sam Seneff is here.
Sam Seneff, and I'm the other analyst with HOPA.
Karen Thomas.
And I'm Karen Thomas. I'm the clerk of the HHS committee. Should you need assistance, please email me at hhs@legislature.maine.gov.
So unless the analysts have something else for us to start with, then I will proceed to welcome someone to present the prenatal care report pursuant to some work by the Permanent Commission, and hear what they have to say about prenatal care disparities. So I welcome Whitney Parrish.
Good morning, and thank you to the committee. Thank you, chairs, for having the Permanent Commission. Before I start, I do have a PowerPoint. I don't know if that's something that can be shared or not. I did send it over to Karen. I
Yeah,
can certainly read from it, but I'm
I
not
think
sure.
on a presentation, that's perfectly okay. So
Okay.
while that's being set up, you should have ability to share.
Yeah.
Okay, great.
And the other thing is, would you like to take questions at the end or as you go along? We want to make sure you have plenty of time to present what you have to present.
I give you
We
all
could
your
save them till the end.
preference either. I think at the end would be fine.
Yeah.
Thank you.
Yep.
All right, let's see. And let's see if
There we go.
my few years of doing this pays off. We will see. Trying to get, there we go. Okay, so thank you again to the committee. My name is Whitney Parrish. I am the acting executive director of the Permanent Commission on the Status of Racial, Indigenous, and Tribal Populations. I actually had all of my notes on my screen, so I'm going to do my very best to work through this. And so maybe it would be easier if I just gave you an overview and stop sharing my screen. So let me do that. This will certainly be available to everyone at the end of the presentation, and I'm happy to take questions at the end. So again, thank you to the committee. Thank you to the Maine Women's Lobby Education Fund for helping conduct the coordination that led to this report being generated. And to the Cutler Institute for their work on a literature review that is connected to the bill that we can provide if desired to committee members, and to the many members of the Community Advisory Committee and key informants, as well as organizations like Wabanaki Public Health and Wellness, Mano and Mano, and others outlined in the report. I know you have the report with you, and as well to the community members who have trusted us with their lived experiences as we work to formulate solutions that are for and by them. So just briefly about the Permanent Commission for anyone who is not familiar with us. We were established in 2019 through Maine law, and the Permanent Commission is an independent entity with a mission to examine racial disparities across Maine and work toward improving the status and outcomes for currently and historically marginalized racial, Indigenous, and tribal populations. Further, the Permanent Commission is empowered by state law to advise and consult on all three branches of government. The commission comprises individuals of many communities and sectors and is co-chaired by Representative Rachel Talbot Ross and Ambassador Molly and Dana of the Penobscot Nation. So I have a few terms that you're going to hear from me today that I'll go over just briefly. And so when we're talking about this issue, some of the key terms are, you'll hear me say BIPOC. So Black and African-American and Black or African-American, Indigenous, and other people of color. It's an acronym. I'll talk a bit about obviously maternal mortality. So death while pregnant or within 42 days of the end of pregnancy, irrespective of the duration of the pregnancy or from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. And again, you'll have all of these definitions. PRAMS, I know many folks on this committee know, Pregnancy Risk Assessment Monitoring System. And we talk about racism. So there are some definitions connected to those as well. So structural racism, a system in which public policies, institutional practices, cultural representations, and other norms work in various ways, often reinforcing to perpetuate inequity for racial groups. So that's a bit about that. And so the directives of LD 1113, 1113 were to one, study the extent of disparities in access to prenatal care for the state's racial, indigenous, and tribal populations through data and other information. So you'll see from the literature review that there was a lot of data that was combed through to this effect. Study the causes of the disparities in access to prenatal care, including through interviews with women who had no prenatal visits until the last trimester or had no prenatal care at all, and recommend solutions to disparities in access to prenatal care in the state. And again, the Permanent Commission did contract with the Maine Women's Lobby Education Fund to coordinate this effort, bring together stakeholders, and complete this report. So what is the problem? The problem that we're addressing is maternal mortality and disparities by race and ethnicity. So maternal health, as many know, in the United States is the worst in the developed world. The fact that the US has the highest maternal mortality ratio among wealthy countries, even when we limit the US data only to white women and pregnant people, suggests that our maternal health care system needs dramatic change, as has been identified by this committee in the past. Access to prenatal care is one approach that improves maternal health for all communities. So making sure that people have appropriate access, that they have access at all. And we'll go over some of the determinants that define whether or not someone is able to. And the reality that BIPOC communities not only have worse maternal health outcomes in Maine, they have reduced access to prenatal care as well. So this uninterrupted prenatal care is a really important factor when we're talking about maternal health outcomes. Structural racism, as was mentioned, leads to disparities in income, housing, safety, education, and other circumstances that are often associated with poorer health and increased rates of chronic disease. This in turn puts many marginalized groups, especially Black women, at greater risk than their white counterparts of pregnancy-related deaths from things like hypertension, among other things, other causes. And so when we're talking about this issue, we're talking about needing to improve women's health services before and after pregnancy, not just at the time of birth. So you'll see some of the recommendations really lift that up, that it's so critical to have the support before pregnant, during pregnancy, and after. So we took a threefold approach at gathering this information and bringing this report to you. One was the literature review I've mentioned, which assesses and compiles currently available quantitative data and interviewed key informants. Some of those were from the state of Maine, some from Wabanaki Public Health and Wellness, from Penobscot Tribal Health Services, et cetera. Because of the really short time frame in which to do the work, it was extremely difficult to bring together individuals who had the lived experience that we're looking at today. And so because of that limitation of time and needing to build trust with community members, which is absolutely critical to doing this work and gathering this information, an advisory group comprising community experts and representatives of identified communities was pulled together. As well, these advisory group members engaged in efforts to gather qualitative data from their communities. So that looked like surveys to members of different groups like Survivors Speak USA, a survivor-led organization working, led by and working with survivors of sex trafficking and sexploitation. Mano and Mano interviewed some of their folks with whom they work, and other organizations interviewed or spoke with their folks. So one area that the report really pulls out is this need for qualitative data. And we see this as a real critical gap when we talk about these issues. In the report, you'll see, we really highlight that lived experience is real and it can't always be quantified or represented in traditional ways. This was something really highlighted to us by community members of racial, indigenous, and tribal populations, particularly tribal populations around data sovereignty and owning your information. While public health data shines a light on some aspects of our community's health and wellness, it does fall short in helping us understand and illustrate the nature and depth of real experiences of human beings within their communities. So a sole focus on mainstream data can be uniquely harmful when it comes to addressing the BIPOC community that this report seeks to highlight. One advisory group participant noted that, quote, "The more we look at existing data sets, the more we make the people with lived experience invisible. The existing data sets were designed originally to exclude the people who are most left out of the process and will be the ones not served by the existing data," end quote. Another noted that, quote, "It's not just about numbers, it's about people's lives," end quote. And I think a lot about COVID-19 and the pandemic when I read these quotes, when Dr. Shaw would highlight these numbers aren't numbers, these are real people with real families and real experiences. And we need to figure out if and how we capture the essence of that through qualitative data. And we believe that can make all the difference as we explore solutions. One challenge though with qualitative data that we ran into with this is that research fatigue is very real. Community members have expressed the sentiment that they don't have the capacity to continue offering up their stories and their trauma to providers. And so we have a meaningful opportunity to reassess the ways in which stories and experiences can be integrated into larger data collection processes. And part of that research fatigue, one way to potentially ameliorate that is really building community trust and systems that are designed by and for people who are most impacted. So just an overview of some key findings from the research on maternal outcomes in Maine. Between 2000 and 2020, the percentage of births to people who were born outside of the US increased by 81%. So we have a large immigrant population and folks are having children here. Vast majority of births, 97.7, were within hospitals. This was between 2016 and 2020. And a really important piece to pull out from here as well is morbidity rates. So while this really focused on mortality, morbidity, or the really serious complications that can arise and cause near death, it was noted through the quantitative research that Black Mainers were at 176% higher risk of complications during delivery hospitalizations compared to their white counterparts. And this is between 2016 and 2020. I do have a PRAMS access to prenatal care when you want it, when you need it chart that again will be in the PowerPoint that we will get to you. But it compares the white subset getting prenatal care as early as wanted at 90.5%, and Black and African American people at 60.3%. So a huge disparity. So disparity drivers, that's a really big question here, right? What is causing these disparities? Many factors drive disparities when we observe maternal health outcomes and health outcomes generally among BIPOC communities. Our report does group them into 4 broad categories. 1, racism, 2, structural barriers, 3, the social determinants of health, and 4, community norms. And those are summarized through national and local research. So racism, while these all, they all crop up in the other 3, these disparities, it's absolutely important to know at the beginning, still exists between Black and white populations, even when their personal and community characteristics like income, insurance coverage at the time, et cetera, are taken into account. So one, structural racism. Is still provider behavior and discrimination that is highlighted as a challenge in establishing trust with a patient and ensuring that uninterrupted care. Miscommunication and lack of trust, as I just said, between patient and provider, and previous negative experiences. We heard a lot about people who just did not want to come back because they had such negative experiences. Poor quality of care, a lack of agency, not being believed to know what an individual needs, concerns dismissed and treatments delayed. We hear about this among women generally with pain levels not being believed, and that's well documented through data. It's compounded when you add race in as a factor, and language barriers. Chronic stress that just contributes to poor health outcomes generally. So chronic stress from racism that spikes hormones like cortisol, gives sort of a cortisol bath to a fetus, and can lead to chronic inflammation. Trauma and stress related to migration for folks who are new to the US, and other environmental factors. And then generally distrust of systems, previous negative experiences, as I highlighted, fear of disproportionate contact with the child welfare system, especially for folks who experience problematic substance use. And I know this committee hears a lot about that issue, and so I wanted to lift that up as well. Structural barriers, these are not new to you. I'm certain of that. Lack of providers, so lack of availability due to rurality. You may know the statistic, but there are on average 67 providers per 100,000 people in rural counties in Maine, 85. So I'm sorry, I misspoke. The Maine average is 67 per 100,000, 85 and 45 respectively for urban and rural per 100,000. In Piscataquis County alone, there are 18 providers per 100,000 people. So that's a huge, a huge issue that affects folks. Lack of representation in the workforce. Nationally, racial and ethnic groups make up 12.3% of physician workforce. While we're talking about all providers, this does highlight physicians. Well, they comprise 40% of the population. Lack of insurance. So lack of and disruption of coverage is at higher rates during and after pregnancy. And people of reproductive age in Maine, 15 to 49, are more likely to be uninsured than the population at large. So that obviously impacts that access to prenatal care, care prior to and after birth. Barriers related to insurance were echoed throughout this work. One quote is, quote, "Some doctors won't take women that have different insurance, or you're uninsured waiting for main care." One individual said, quote, "If you don't know it's available, it's not available." And then the belief and the reality that specifically with main care, that there's a denial first, and it feels like it takes a few times to be accepted and have access even when there's qualification. So main care was cited as challenging to navigate. And for many, pregnancies have progressed into the second and third trimester by the time coverage does kick in. As well, cost barriers, that's a huge one. One participant said, quote, "Receiving a bill for a care received and not being able to afford it is one of the biggest fears that keeps people from seeking care, though they know they need it." Citizenship, political status, and location are all factors with insurance, et cetera. And location, especially when we talk about rurality and access to care and providers. I'm going to speed along pretty quickly. I know we're almost out of time. Social determinants of health, so socioeconomic factors, the cost of care we've discussed, access to transportation to get to your appointments, employment that doesn't allow you to take time off. These are things many folks experience, and especially BIPOC folks who may work certain types of jobs in the service industries and other caregiving jobs. Regional factors, as was pointed out, and lack of transportation broadly, that's a huge driver. And then community norms, specifically among our immigrant communities. So skepticism about practices, a fear of cesarean intervention, sort of this, the rush medical intervention where folks have had unsafe C-sections in the past and rushed labor. And also that pregnancy is not a sickness. That's a quote that in many communities, it is believed that you go to a doctor for curative care, not preventative care. So education around those issues is really critical. And as well, language barriers, et cetera. So recommendations based on all of this information. We believe expanding community-led data gathering and aligning that with state systems is critically important. Investing in relationship-centered care, addressing structural inequities, enhancing statewide data collection to better serve communities, and supporting community-led education. So briefly, community-led data gathering, investing in systems that support community-led and culturally specific fact-finding, story gathering, and qualitative data gathering. Maine's data and information systems broadly can and need to be expanded and improved to meaningfully center the experiences of BIPOC communities. And this really transcends the racial disparities issue, and we just need better, richer, more granular data when we're discussing these issues and how to solve them, as well consulting with the Maine CDC, DHHS, and others to ensure that efforts in the state are aligned. Investing in relationship-centered care, so listening to the direct needs of folks and letting them lead their pregnancy and their birth while providing optimum support. Expanding things like doula services. Many states have looked at Medicaid covered doulas. So a doula is someone who's a trained non-medical pregnancy support person who offers guidance to a birthing person. And sometimes this is prior to birth and postpartum. Expanding access to midwifery and non-hospital births. Building trust between providers and pregnant people. And then support before, during, and after pregnancy is absolutely critical. And those structural inequities, increasing of accessibility to prenatal care, addressing the critical health insurance gaps. And while this committee did increase Maine care access up to 12 months after giving birth, we do believe that that continuous coverage is really important. So expanding coverage to people who maybe make more money, but are right on that cusp and still need support, engaging BIPOC communities to ask what the best ways are to reduce racism within healthcare settings, and identifying community liaisons in healthcare settings. And education. Education is so critically important. It needs to be BIPOC-led and centered. And so providing funding for these types of community outreach efforts is absolutely essential. And I've talked about data collection quite a bit, but there is more on that, and developing research and evaluation approaches that do center participatory efforts that strengthen data collection and community involvement. We have to build trust with our community members so that we can solve these really, really pressing issues. So I did run through that pretty quickly. It's a lot of information, as you can see from the report. And so I just want to thank you again. I'm happy to take questions. I think I expended my time, so I will stop talking. But again, I'm happy to provide the report and the PowerPoint to everyone as soon as you like. Thank you.
So thank you for that. And it was a lot of information. Do you think you could put your presentation back up and then go to the pages with recommendations?
Sure.
I think that'd be a little bit easier for us to follow.
Absolutely. Let's see. Let me go back to, and I apologize, you mentioned technology challenges, and here we are. So let's let's see. And each, I apologize. So, and I think you might be able to see my screen there.
Recommendations, yes.
Yes, so, and I can move this. Again, I apologize.
Do you have, are there specific suggestions under each of these 5 areas?
Yes.
And which of them might benefit from legislation, and which of them are community and department work?
Yeah, no, that's a great question. So we did, I did have these slides that sort of involve in some specific recommendations, and then of course the report expands on that a bit, or quite a bit actually. But I think in particular, while this community-led and culturally specific data gathering happens, really consulting, so that's not as legislative, that's more procedural. Investing in relationship-centered care. I don't believe there was a direct legislative fix coming out of that beyond just having more incentives for providers to come here, to be here. And it was, highlighted that earmarking funding for workforce development and educational opportunities is a really important piece here. And, we do highlight that in October of 2021, Governor Mills did announce tuition reimbursement program to provide financial support to attain healthcare credentials, et cetera, and more work on that. We believe would be really important, especially to attract folks who are representative of their communities and are able to provide a care in a different way, maybe than an individual who has not experienced the same things. Expansion of midwifery practices would fall under that as well, where many BIPOC individuals really value the midwifery sort of style, so to speak, and feel it's a little more personal. I've experienced all of them, and I would say that that's a big part of this. So just incentivizing folks to engage this work and really support people as well. The expansion of access to doula services and the potential for that to be covered by Main Care or Medicaid would be potentially a huge benefit to folks because it is that non-clinical relationship that really supplements that nurse midwife or physician obstetrician really helps bridge the gap for folks in many ways and provide some advocacy if needed and just general support. Health insurance, as you mentioned, was the biggest thing that came up here. So again, the expansion of up to 12 months after giving birth is huge. And looking at more ways to expand coverage before, during, and after pregnancy. So really being able to get a handle on your, whatever underlying health condition you might have prior to pregnancy is absolutely critical. There are health conditions that happen after pregnancy. I won't center myself. I will give an example. I did not have hypertension until after pregnancy. And so that is something that I treat now postpartum. And so, sort of extrapolating that, there are many folks, and I was one of these who lost coverage the month after I gave birth. And so this legislation is absolutely critical and could be expanded upon potentially. Ensure that the workforce is adequate. I think I expounded upon that. And then developing ways to have community liaisons. That could be through hospitals, it could be programmatically, or there may be ways legislatively to support funding of those positions or establishing those things. And funding is a very big piece of this. So finding funding that can be dedicated to educational programming, especially for populations who don't know how to navigate our systems, don't understand them, and don't trust them because of things like language barriers or other reasons. And so identifying funding across the board to support these efforts is absolutely huge and could be supportive legislatively. So.
Thank you.
Absolutely. Thank you.
I see a question from Representative Perry.
Yes, and the question I have as I look at this information, there is every 4 years there's a population health document that gets put together in terms of what's happening with health. And I'm thinking is that perhaps looking at some of this stuff is this might be some information that's worth incorporating into that population health project. It could also give us a good look at what's trending, whether it's trending up, whether it's trending down, and give us a better idea. I don't know what we would have to do to sort of add something like that to the population health thing, but it is a suggestion, and maybe talking with the CDC might be helpful with that.
May I respond?
Sure.
Great. Thank you, Representative Perry. That is one recommendation we had, and I think it's not in the PowerPoint, but it is in the report. But even adding questions to PRAMs regarding, were there experiences of racism, for example? How do those, and then we can look at those trends and how do we address those things? And I think that's a really wonderful example of how we can use the traditional data methods and start really getting to the heart of some of the questions we need to be asking of community members in conjunction with some of the qualitative data gathering that could be sort of woven into that data that is gathered through these initiatives, as you mentioned. So thank you. It's a great
suggestion. Are there other questions for Whitney? Did you, were there success stories that you came across that might serve as models or beacons for future change?
Yeah, that's one thing that I think the report doesn't highlight as much and could. It's a lot of sort of where are the gaps and what were the negative experiences of folks who were interviewed. And I think that's where this did become a challenge in terms of interviewing folks and getting a really comprehensive view and asking, what is working and how do we build off of that? And so there is hope beyond this legislation to continue the advisory group and the work group more broadly in terms of gathering more information that I think would speak really well, hopefully, to your question. In terms of the report, there isn't a lot in there right now, but we do hear that, we hear about folks' preference of care, or, if I had just been called back about this, I may have made it to my appointment. And so those are sort of little things that become much bigger when someone, doesn't go to their appointment or can't go to their appointment. But just identifying simple things like that, folks did do that. And they said it made a world of difference just to feel like they were cared for and cared about. But to your question specifically, I think that's something that we can really hone in on as we look at sort of the next stages of what qualitative data could look like and how the state could use that when formulating recommendations and executing them. So thank you for lifting that up.
So that's a commitment that this work group has, is to continue to do this work and explore some of these issues?
Yes.
Great. So that would create the opportunity for an annual report back.
Potentially, yes.
Just saying. Okay. And I know that the reason I asked about examples is that people doing the work or trying to get the work done are much more likely to listen to people who are doing it and have been successful than
Absolutely.
they are to legislatures, legislation, and the department.
Sure. Yeah, absolutely. And the Community Advisory Board comprises physicians, midwives, community leaders, people who have experienced directly these things. And so that is something I can also bring back if the committee would like to hear more about those pieces of that, the issue. We certainly don't need to wait a year. If that is something the committee would like to look at, I can certainly get that information.
Okay. Why don't you give us a chance to review what you presented and the report, and we can decide if there's a particular invitation for write-off or not.
Sure.
Are there any other questions of Whitney? I'm not seeing any. So we thank you for bringing that. We thank you for whatever your contribution was for getting that report done and to us. And we'll go from here, learn and see if there's some other places we can help in the process. But this is a good start.
Great. Thank you very much for the opportunity. Have a wonderful day.
You too. So that's the first item on our morning agenda. The next item is a review of the PTP work group. So just briefly, for those of you who haven't had a chance to think about PTP, Progressive Treatment Program, since the last time we considered the bill, and it got turned into a work group. I just highlight that this is a way to get somebody treatment against their best judgment. And it's used only after somebody has been hospitalized and a PTP, a plan has been put in place, after it's been recognized that certain individuals, as part of their mental health challenges, their serious mental illness, don't appreciate that they need help. And that's the term anosognosia that the Honorable Representative Nutting introduced us to, which I can now both say and spell, which I didn't used to be able to until John and I started corresponding regularly. So anosognosia is a real barrier for a small subset of people. And the way to keep them off the streets, out of jails, and out of hospitals is to make them get therapy that they really don't want because they don't recognize that they need it. So it's a very small subset of the folks with serious mental illness who need PTP programs. There's a big gap between what our statutes say is permissible and the groups that can bring requests for PTP court hearings, and that there are several barriers. One of the largest is the cost of putting together a PTP application to the courts. So Ann will speak to that issue a little bit later on. Another is a lot of people just don't know that they can do that. The way the statute's written, providers, police, ACT teams, a number of different people can bring requests to the local courts for a PTP hearing. But basically, it's done by the two institutions that are the state psychiatric hospitals. And we were looking for some options that would broaden that out a little bit. So that's that's the PTP overview that we went into. We were trying to sort out what the barriers are to using it more, what the barriers are to using it at all. And then if there were some things we could do legislatively that might help. So that's my in the trenches version of PTP. And I invite any of the people who really do that work. I'm thinking about Representative Madigan and to comment or supplement that before we get to Ann's presentation of the two bills that we're considering. Did you want to jump in, Representative Madigan?
No, I'm willing to listen. Just I have to jump off at 11 because I have work sessions in HCFIS. So
Okay. All right. And we welcome Representative Stover. Did you want to introduce yourself?
Yes, thank you, Senator. My name is Holly Stover. I represent House District 89, including the towns of Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol.
We've just started to consider progressive treatment programs, and I did a little bit of a unsophisticated overview, and Ann Perry's going to get into the weeds with what we learned from the work group and what we think might be reasonable legislation. So I'll turn it over to you, Representative Perry. When you're unmuted, particularly. Looks like you're still muted.
I was busy looking things up on my computer and I couldn't find our faces again to make sure that I have what I wanted to bring forward. The report Anna gave us a link to, which really talks about the process. And the two bills that brought this forward was really not only about PTP, but the green paper process. And I will say, as we went through those meetings, I learned a great deal about the PTP process, and also learned that the green paper process is quite confusing. I think that's the best way I could describe it. Simply because there is this process of being in the hospital. If you're in PTP, which is the green paper process, and you have to be re-hospitalized, the one thing that the concern was, if you were in a program that was working, this is a slip. There's nothing that guarantees that they will actually be able to get back into a program that was working and end up starting out all over again. So there was a whole lot in these conversations. We actually extended some meetings as a result of that. So in the report, you will see that the recommendations are recommendations that was agreed upon by everybody, and then recommendations that were not consensus born. And so as we go forward, looking at the report, Senator Claxton and I really looked at that and thought that there are two things we should do now. And those are the pieces that were agreed upon by everybody. And we put them in two bills, partly because one would be very much just a financing bill, which should be that altogether. And that is recommendation number 2, which is to establish a new fund administered by DHHS in reimbursement for legal costs for private entities for the PTP initiation and maintenance. And that's the green paper issue. The second bill, we've combined recommendations 1 and 2, because, and this, I'm going to say is my feeling as well, is the recommendation is for a monitor for the PTP that's within DHHS and the Office of Behavioral Health. That would, there was confusion, and I think we really need to define the confusion about what the green paper is, what PTP is, what's the relationship, looking at ACT teams and law enforcement training around this as well. And also a monitor who looks to ensure patients' rights during this process. So with assessment and treatment, and collects data on PTP outcomes statewide. It'll give us a good picture. The other part of that bill will be either to recommend or establish, and I will need more as to what the department can do, a mechanism to maintain an existing PTP during an involuntary hospitalization, based on the district court commitment, And the ability is to have a continuation once they get out of the hospital without having to start all over again. And to try to develop a process that would allow that to happen. That's the second bill. If you have any questions, we'll try to answer them.
So I will point out that the things that we've included in our bill proposal were not all universally accepted. As you go to page 11 of the report that Anna linked to, you can see what the votes were. And the synopsis is the more blue, the better. But there was disagreement on 7 of the 9 issues, which is why we chose not to get too specific. The barrier for the application process is that it can run in the $800 or $900 range to get one of these programs in place, because it involves court costs, court time, lawyers, all kinds of research. So that was a reason that a small police force wouldn't take on such a task, or that folks that didn't have deep enough pockets. So that was what we were trying to address with the funding mechanism. And obviously, the department would have to draw up rules of how the reimbursement was handled. And we'd have to figure out how big the fund was. But there are relatively few people who currently have a PTP. Representative Perry, was that about 100? Do I remember that number?
I don't remember.
Okay, but arguably it could be a whole lot bigger. And then the other thing was that there seems like a lot of programmatic work that could be done, and that's what the role of the monitor would be, to help people understand what this is all about, what a green paper really is, to begin to develop some rules. Because right now, if you end up going into the hospital with a PTP, it evaporates and you have to start all over again, which seemed crazy to me, but that's the way it's handled. That if you end up being hospitalized, all of the work that went into developing the prior PTP goes out the window. Now, in some instances, the PTPs have gotten too specific and uniformly unachievable. So we also have included some suggestions for the monitor to work on plans that would be really the highest priority issues for an individual, but keep them out of hospitals and jails. And the evidence shows, and certainly evidence from our state does, and from other states, so that for the people who are operating under a PTP, their entry into jails and entry into hospitals is much reduced. The other thing we have is that there's these people tend to cycle. So they get out, get worse, get back in, get out, get worse, get back in. So they're occupying beds over the course of a year, when if they could just get stabilized and stay that way for a while, we might free up beds and make more psychiatric beds available. So those are some of the things we are shooting for, and that was what we came down on, and did a lot of the detail work on that. So I understand the big picture, and she's into the weeds better than I am. So thank you for that. Any questions or comments about this? So the plan is to work with our analysts and bring forward 2 different bills, and then give the committee a chance to consider those, add or subtract, and work on them the way we normally would. So any questions, suggestions beyond that? And Anna is going to make our musings, help make our musings into bills. And we'll be working with ROS obviously too. Oh, it's Sam who's going to be doing that. All right. Oh, that's right, because she said we needed a lawyer to do some of this stuff. A real lawyer. All right. So thank you, Representative Perry, for that. Very interesting meeting, and the meetings were enough to help us understand what we don't know and begin to address those things for folks who are in desperate need of better access to PTP programs. That was one of our huge take-homes. They don't know it, they may not recognize it, but certainly their family and friends do. And anything we can do to help them stabilize their lives within reason and with respect for patient rights, which is why you go through the courts, are definitely worth working on. Okay, so Sam, we can give you the outline of, or if you haven't seen it already, did you send that along, Representative Perry, to Sam?
Yeah, I'll do that.
Okay, so we have a draft of our bullet points, and we're open to suggestions before we send it to ROS, which will happen without committee activity and in the background. All right, are there any other items for consideration this morning that didn't make it onto the printed agenda that I have? I'm looking for a head shake from Sam, a hand up from Representative Perry.
Oops, sorry. I would like to, if we can this morning, I would like to re-vote on LD 1792. And that's the bill for the increases for the Riverside and Dorothea Dix. I guess I could make that a motion. I'd like to explain why I'm doing this.
Why don't you make the motion then for reconsideration?
I'd like to make a motion for reconsideration of LD 1792.
1792.
I will second that.
Okay, there's a motion and a second for reconsideration. Representative Perry.
Thank you. It was a really difficult vote, and I think if I had more time to think, I would have voted differently. Again, the reason I'm voting it has nothing to do with the hard work that these people do and what they're required to do on a day-to-day basis. This is not even just for the pandemic, day-to-day basis. They really do hard work. However, when I look at the number of the classifications that get affected by this and the inequity that it creates along those classifications, I can't in good conscience create a greater problem than we have right now. And I feel that this is exactly what happens. So I am asking, and thank you for allowing this to happen, to change my vote.
So technically, we need to vote on the motion. There's a motion on the floor for reconsideration.
Vote,
So
reconsider, thank you.
I guess, Senator Moore, I saw your hand.
I was just going to say, do we just want to show of hands for the reconsideration, or do we have to take a formal vote?
I think we've been working together long enough. We can do it with a show of hands, if everybody's okay with that. If anybody would like to recorded vote, I'll do it that way. But okay, let's do it with a show of hands. Those who are okay with reconsideration, please. That's unanimous of those present for the record. Thank you very much. So is there any other comments related to reconsideration of LD 1792? Before we go to Karen and revoting this, the motion was made by Representative Perry and seconded by Representative Craven. And I'm not seeing any comments, so we can turn the vote over to Karen to run that, if you would, please.
Senator, what was the bill number again, please?
1792. That's the bill that I think we know as the $3 an hour for Riverview and Dorothea Dix. At least that's the way it is in my head.
And Sam actually sent us earlier the actual bill, the minority report and the majority report, so that we had to sign off on it. So we just received that recently. I don't know if everybody's looked at that.
Yeah.
Yes, yesterday. It came to you yesterday.
And so we will, whenever the vote is taken, we'll make sure that that gets in as the corrected version of the vote that's submitted.
Okay, just for my clarification.
We're voting on LD 1792 as if we hadn't voted before.
Okay.
And the motion, the original motion was ought to pass as amended.
Correct.
On 1792. Yes. So if you could run the vote on the motion ought to pass as amended.
Okay, Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin,
No.
Representative Lemlin, no. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry,
No.
Representative Perry, no. Representative Javner. Representative Javner is absent. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Connor. Representative Connor is absent. Representative Griffin.
No.
Representative Griffin, no. Senator Moore.
No.
Senator Moore, no. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. Thank you.
So that's 6 yes, 4 no, and 3 absent. Thank you all for that. And I appreciate Representative Perry's sharing her thinking with us. Tough vote. Okay. Any other items to come before us?
One more clarification. Sorry, Senator. So
Please.
the minority report is ought not to pass.
Well, technically, we have to wait for the other 3 votes to come in, so we may need to record it, but the minority report was ought not to pass.
Okay. Thank you.
Sam,
I do have a note that it was ought not to pass with a letter to the department.
yeah.
Thank you,
So I
Sam.
don't
I
think,
meant to add that.
okay, thank you, Sam. Okay, any other business that somebody would like to bring up? Not seeing any. I think we will adjourn until 1 o'clock, at which point we will consider 3 bills.
Excuse
in
me,
work-
I'm sorry, Senator. Can I stop you for a moment?
Sure.
If you want to report out bills pursuant to PTP, you're going to need motions to do that. Otherwise, we can't get started on it.
Oh, okay. So I'll entertain a motion. So would you have to do them individually? In the motions, Anna?
I don't know if I know the answer to that. I'm not sure it really matters, but I just
Okay,
checked
well,
with
we'll
my
do it-
boss
we'll do
and
it.
you do need a motion.
Okay, we'll do it one at a time. How about that? So I'll entertain a motion to establish a fund. Representative Perry.
I would like to make that motion.
Or no, second it.
So it's been moved and seconded by Representative Perry, moved by Representative Perry and seconded by Representative Craven. The motion would be to establish a fund from which DHHS would reimburse for the costs of PTP applications for those organizations who needed the help with the department setting up those rules. Any further discussion of that particular motion? All those in favor of the motion, I think we can do that with a show of hands too. That's unanimous of those present. Thank you. So then we'd entertain a second motion to establish a monitor with some defined job responsibilities and some funding. Representative Perry.
I will make that motion.
Second.
And Representative Craven has seconded. Any discussion about that particular motion? So we're voting to authorize legislation be drafted, and we'll have a chance to consider at future public hearing. All those in favor, please so indicate, hands up. That is a unanimous of those present. Thank you for that. Any other suggestions before we adjourn until 1 o'clock? Not seeing any, we'll reconvene for consideration of 3 bills in a work session this afternoon at 1 o'clock. Thank you all for this morning's work. Oh, there's Representative Javner. Welcome back.
Snow day's over. Time to get back to work.
At least you're getting snow.
Well, we were rain, then it changed to snow, then it's rain again. So you guys can watch what it does behind me.
So you have the duty this afternoon, Sam? So it's 1 o'clock and we had previously convened for an information session. This is now the afternoon session of the Joint Standing Committee on Health and Human Services. We'll be considering 3 bills this afternoon. We've had a request for LD 1909 to be last, and we'll respect that. And so why don't we just start with LD 1582, if you're ready for that, Sam. And we'll give Representative Javner a chance to introduce himself.
Thank you very much, Senator Claxton. This is Representative Kathy Javner, and I represent House District 141, which is located in Penobscot in Washington County.
Thank you. All right, Sam, you're up.
All right, I'm going to go ahead and share my screen.
And will everybody notice the enhancement on our logo page? Now considering LD 1582. Thank you for that, Karen.
All right, so this
So
is
this
15.
is a work session consideration of LD 1582.
So I am going to start with a summary here. I'm not going to read every word here because it is rather long. So I'm going to hit kind of some of the bigger points. But I did try to be very detailed in my summary because the bill itself is quite dense. So this is LD 1582, to enact the Maine Psilocybin Services Act. So this bill enacts the Maine Psilocybin Services Act, which establishes a regulatory framework in order to provide psilocybin products to clients in Maine. So the bill provides for an amendment to Title 28B, which is the adult use marijuana title, and it renames it the Adult Use Marijuana and Psilocybin Act and establishes within that the Maine Psilocybin Services Act in Part 2. And Part 1 would be the adult use marijuana. It establishes the Maine Psilocybin Advisory Board, which will include 19 members and has a number of duties, including making recommendations to DHHS, monitoring federal laws, creating a long-term strategic plan, and reporting back to the department, among other duties. It exempts individuals licensed to possess psilocybin from civil and criminal liability for use of drug paraphernalia. It makes clear that it doesn't impact the duties of main care or private health insurers to reimburse for costs associated with the use of psilocybin. Makes no change to employment law, landlord-tenant matters. It does not prohibit a recipient or applicant for a federal grant for prohibiting psilocybin use or manufacture. It doesn't prohibit a party to a federal contract from prohibiting the use of or manufacture or possession of psilocybin. Does not require that a person violate federal law or to exempt a person from federal law or allow a person to obstruct the enforcement of federal law. There's quite a bit of direction for DHHS to adopt rules throughout the text of the bill, including rules for licensing, tracking, monitoring, psilocybin, and there's multiple different license types that the HHS would be responsible for. It provides that a client may purchase, possess, or consume a psilocybin product only at a psilocybin service center and only under the supervision of a psilocybin service facilitator. It includes an age restriction to folks over 21 years of age and older. It does establish a number of crimes for various violations of the Act. And I did try to, every time there was a new crime mentioned, to include that in the summary, so you could get a handle of what those would look like. It requires DHHS to publish on a publicly accessible website information about medical, psychological, and scientific studies and other research related to psilocybin. It requires DHHS to maintain a telephone hotline for certain government designees to inquire if an address is the location of a licensee's premises. It keeps confidential certain information held by DHHS in relation to psilocybin licenses. It does require, so the license, the date that DHHS is required to start issuing licenses is January 15th, 2023. This bill was introduced in the first session, so it may be that there are some dates that would need to be pushed back because this was a carried over bill, so kind of it delayed things a bit. Let's see, what else did I want to point out to you? It does establish prohibited conduct, and those are laid out pretty specifically for different license types, and as well as the consequences for violation. It requires DHHS to adopt rules governing administration and integration sessions. Those are defined in the statute, again, with a fair degree of detail. It has a number of requirements relating to municipalities and their ability to adopt ordinances that impose some restrictions on psilocybin. It also includes, it allows the governing body of municipality to prohibit the establishment and operation of psilocybin manufacturing facilities and service centers, but it also requires that if there is a prohibition adopted or removal of a prohibition, that measure has to be submitted to the electors of the municipality or within the unaffected organized territory for approval at a statewide general election. So it does include that kind of second step. And the measure would take effect only if approved by a majority of the electors voting in that election. Let's see. Again, establishes a number of crimes for license violations as well as administrative penalties. It establishes the Psilocybin Control and Regulation Fund, which is to be funded with money received from license fees and various administrative penalties and other sources. Money credited to the fund may be used by the department for purposes of implementing, administering, and enforcing the Psilocybin Services Act. And it also imposes a tax of 15% upon the retail sale of psilocybin products, and provides that for the purpose of compensating psilocybin service center operators, each psilocybin service center may deduct and retain 2% for that purpose. Let's see. Again, rulemaking deadlines. There's a for the Psilocybin Services Act, November 15th, 2023, again, may need to be adjusted. And it also requires that DHHS consult with Department of Agriculture, Conservation, Forestry, as well as the tax assessor to develop recommendations to conform to the act and to otherwise make the act as consistent as possible to the substance of the laws governing psilocybin in Oregon. So there's a lot here. And I just wanted to point out that just given the breadth of the bill, there are going to be issues here that I likely didn't pick up on. just because it is so dense. So this is probably a bill that would require review by various administrative agencies to just make sure that there's not issues that are impacting those agencies that are kind of embedded in this bill. So issues from testimony, many commenters testified as to the medicinal value of psilocybin in the treatment of a number of medical conditions. Maine Revenue Services did testify that they requested that the taxation of psilocybin products be incorporated into Maine's existing sales tax structure instead of creating its own tax structure. Maine Municipal Association also expressed concern that the bill assumes psilocybin services are authorized unless the community moves to opt out. And they also noted the requirement for approval by the legislative body, and that decision be agreed to at a subsequent statewide general election, which is held in November. They were concerned that this timing could be an issue and that it could enable providers to operate before voters had a chance to act. Some commenters did raise concerns that psilocybin has not yet been fully vetted by the FDA. Some commenters raised concerns that the bill does not provide for medical supervision of psilocybin use. Others argued that it provided for adequate protection. Some commenters suggested the bill be amended to allow for use outside of psilocybin service centers. The Maine CDC testified they did express concern that the bill established recreational use rather than medical treatment facilities and put limitations on the department's ability to regulate safe use and did not incorporate sufficient behavioral and public health input. I did just for your reference, went through and listed the various existing laws regarding psilocybin. It is specified in the criminal code. So in you'll see the various references. Sorry, that should be 17A, not 14A. So psilocybin is listed as a Schedule X drug. And so I went through and found the references to various Schedule X crimes. So trafficking, aggravated trafficking, furnishing, aggravated furnishing, possession, acquiring by deception, stealing, illegal importation, and aggravated illegal importation are all Schedule X drugs are all listed there, and you have all those citations there. So this bill, as far as I could tell, doesn't impact any of those. So I did just note that as a potential issue, that there's no removal of psilocybin as a illegal substance in and of itself per state law in the bill. Similarly, psilocybin does remain a Schedule I controlled substance at the federal level. Individuals engaged in research are required to obtain DEA approval in order to study the drug. There is a conflict here potentially with federal law. Again, the bill does not explicitly decriminalize psilocybin use or possession in Maine. I did, just make a note about the complexity of the bill and the potential need for review by involved agencies. The bill creates a number of new crimes, and any bill that creates new crimes does require review by the Committee on Criminal Justice and Public Safety should it receive a positive report out of committee. The bill does not establish a medical model for the use of psilocybin. It is, I think I wouldn't venture a guess either way here, but it's unclear if this could be considered to impinge upon the practice of medicine. And that may be a good question for the Office of the Attorney General and the boards of medicine. There's a number of amendments to Title 25, Section 1542A that relate to fingerprinting that may no longer be necessary because a number of the changes included in the bill were made in another piece of legislation last year. I think it's kind of a minor thing, but I did note it when I was reviewing the bill. A number of deadlines in the bill will need to be adjusted as those have either passed or will not be feasible given the timeline of the second session. Other jurisdictions, so Oregon notably, this bill appears to be based on the Oregon statute. So in November 2020, voters approved an initiative authorizing the Oregon Health Authority to establish a program to permit licensed service providers to administer psilocybin producing mushrooms and fungi products to adults. The text for that act is linked The act is similar again to this act. The Oregon Health Authority's website related to the act is also linked. And they have a subpage for scientific literature review, which I also linked as it might be of interest. DC passed in November 2020 a ballot initiative decriminalizing the personal cultivation and possession of, oh boy, entheogenic plants and fungi, which does include psilocybin. Just some additional links for information for you. There was a New England Journal of Medicine article that was referenced a number of times. I believe this is the journal article that was referenced. I did link that there for you for review. It's quite recent, just from last year. I linked the Johns Hopkins University Center for Psychedelic and Consciousness Research, which is a leading entity doing this work in the medical side, and also the Department of Justice DEA drug fact sheet on psilocybin. And the fiscal impact for this bill has not yet been determined. I'm happy to answer any questions. And this is, again, a pretty dense bill, so I hope I gave you enough information, and happy to go into more research if that's helpful.
Wow, thank you, Sam. That was quite a review. All right. I see we've been joined by the bill sponsor. So Senator Bailey, did you have any comments you wanted to make about the analysis of the bill itself?
Thank you, Senator. I would just echo your comments, Sam. That's an incredible job. It is a dense bill. I wanted to make sure the committee, though, had something to work with. So again, your analysis, I think, was spot on, and kudos to you. I did also just want to mention, as some of you may be aware, we are working on an amendment just based on the public hearing and the questions, comments, and feedback in that to amend the bill and keep the advisory board, and also limit the use to palliative care upon recommendation from a medical provider. So that amendment hasn't been fully fleshed out yet, but that is the direction that we're working with advocates on. So I'm happy to answer any questions committee members may have, or again, I welcome your feedback on our possible amendment and anything else you'd like to see in that. Thank you.
Thank you, Senator Bailey. Are there questions of Sam and the analysis, or of Senator Bailey? I don't see any questions. How about comments in general on the bill and where we might want to go with it in our current session, in today's session? Representative Zager.
Thank you, Mr. Chair. I think it's a very exciting bill, and I really appreciate Senator Bailey bringing it forth. I'm very moved. I was moved in testimony, in the hearing testimony from a father expecting their second child, who said he went from wanting to end his life to loving life, as well as other testimony from the hearing and that I've read about, because we really do need a breakthrough drug for some of the conditions, the substance use disorder conditions and emotional health conditions. And I think that the work that's the research that's going on at Johns Hopkins and that is being under review by the FDA is crucial to make sure that we don't get ahead of ourselves. I feel like this bill might short circuit the usual process for vetting drugs and treatments and therapies to make sure that they're dosed correctly, safely, that they're implemented, and it's part of a whole package of treatment. And so while I'm very excited about the prospect, and I would not be surprised at all if this someday becomes more mainstream and part of comprehensive behavioral health, mental health treatment. I'm not in favor of the bill as presented, although Sam, you did a phenomenal job of presenting it, describing it. But I would be in favor of something along the lines of the council, that would examine this further, because I think there's more work to be done, and we want to make sure that things land smoothly in Maine for people for whom this might help. So I appreciate the chair for letting me share those not so brief comments.
Thank you, Representative. Representative Craven?
Thank you, Mr. Chair. I agree with everything, obviously, that Representative Zager has said. I worry about the bill because it's, besides, it isn't, I know that this has potential, and I see that the Johns Hopkins and also the FDA are doing research here. The biggest worry I have is that this was not presented with medical supervision, with a medical supervision provision. I think to have the medical marijuana organizations who are still trying to get their feet under themselves be the managers of such an untested medication that I think is not a good direction for it to go. And also I worry about something like this going out in referendum. We've heard so much testimony this week and last week, and the general population really, and I'm totally confused because but for this to go to referendum where people don't have this advantage is a dangerous precedence for something like this. And what comes to mind, and I'll shut up, but what comes to mind is how valuable fentanyl was when it was introduced into the medical arena. And now look at us. We have no idea how to pull it back and to to have it now, it's like a poison as opposed to be a useful tool, for palliative care or other kinds of.
We just lost your audio, Representative.
Sorry, so I won't be I won't be supporting the bill as it's written. Thanks.
Representative Meyer?
Thank you, Mr. Chair. And thank you, Senator Bailey, for bringing this forward and as an impetus for this discussion. It's an important discussion. This is a breakthrough therapy and it shows promise, but the science is not there yet. I have concerns as well as a number of municipal officials who have reached out to me here, alarmed at a proposal to establish service centers that would function as recreational use facilities. Just that prospect alone has led to quite a bit of outreach to me on this bill, and I can't say as though I disagree with any of those concerns. I cannot support the bill as it's been presented to us, and with regard to an amendment, I could consider under some circumstances a work group that might look at what's happening federally, nationwide. I know there may be some pilots going on in other places in the country, and to do some work around gathering that information and presenting it to us as we move along and this therapy moves along, in both the FDA's look at it and just the science in general. So with that said, I could not support any amendment that would even propose limited use in any setting with any population in our state.
Thank you. Representative Lemelin?
Thank you, Senator. I'm an odd not to pass because in my opinion, I don't think psychedelic drugs or any drug actually is the way to solve any of these issues. I feel we need to steer clear of these drugs, and I think we need to find other means to help these people. I'm also not for a study or work group. I think we need to steer clear of the whole issue. That's just how I feel. Thank you.
Thank you. Representative Perry?
You're on mute, Representative Perry.
She's looking for her unmute button. It keeps moving.
Sorry, I started to answer, my phone started ringing, and I'm trying to turn the phone off.
That would cost you $5 if we were around the horseshoe.
You didn't hear it, did you? Okay, well, I looked at this bill with a great deal of angst, and I will say why. First of all, we're talking about a medical treatment that has mental health issues. Have we heard about what the side effects are? Have we heard about what issues this really should be prescribed for? Do we know what dosing we're giving and what the process should be? You know, I went through this with medical marijuana, and we allowed it to be done only in certain circumstances. We still don't have that information. But with psilocybin, we have a federal process to okay medications. It's in the process of being okay with all of the guidelines, with the side effects, the positives and the negatives, because there is no drug or herbal or anything that doesn't have side effects. And it always sounds good when it's working, but when it hurts somebody, it is not so good. I think we should allow the process of the FDA to work. And quite honestly, us studying it is not going to make any difference in terms of what the FDA decides. I really prefer to use the FDA process, and seeing it as in that process, I do not want to usurp the FDA's authority. And so I will not be voting for this.
Any other thoughts or comments? Yes, Representative Madigan.
I just want to say that I think the current studies going on now regarding psilocybin and other psychedelics, particularly in regards to the treatment of re-experiencing symptoms in PTSD, are really important, especially when you consider what psychedelics do biochemically and what re-experiencing symptoms are in the brain. I find that that in my work as a therapist, that those symptoms are often very destabilizing for people. And so the thought of something that would be able to address these symptoms, to me, I think would bring relief to a lot of people. And as a mental health professional, that seems really critical to me. On the other hand, I think this bill isn't quite ready. And I hope we can do a lot more studies and figure out a way to get relief to people who experience re-experiencing symptoms and trauma, because it's something that I hope if you've never had to experience it, you never have to, because it's very traumatic for people. So thank you.
Thank you. Just so I have a sense of the committee, one of the possibilities was about the advisory council. That was still to be included in the amendment. I've heard a couple of people say that they aren't interested in that. Is there anybody who's interested in pushing for Is there anybody interested in constituting an advisory council as a way to study the drugs with the assumption that we broaden it to psychedelics? Yes, Representative Zager.
Thank you, Mr. Chair. I think that there's benefit to looking into this. The scope of that of such a working group or advisory panel, have to be clear and thought through. But I'm more or less in favor of examining it, but allowing the FDA process to proceed.
Representative Madigan, thank you.
I was just going to agree with Representative Zager that I would support a working group, but I also think it needs to go through the FDA process and studies. So.
Okay, so I just pose a question to the committee. If the FDA was to approve ecstasy tomorrow as a psychedelic with limited use and very specific guidelines, would we be in a position in the state to allow that? Would it would just be treated like a regular medication? I'm posing a hypothetical instead of the specific, and I'm just trying to think what we would gain. Independent of what we do, the FDA is going to continue its thing. They don't check with us very often. So my question is there some way is there an advantage that hasn't been fully appreciated by the committee yet for looking around, trying to look around the corner a little bit for when that day comes? I'm just floating that. Representative Perry?
Yeah, in floating that, if the FDA approves that, then that will come out as a medication, qualified. The illegality of it will not be there. We'll also know because there will be a requirement on dosing and stuff, and that will go with the FDA approval. And what happens if we go outside of that? Then what do we create? If we create a system that then becomes a medicine, and we've created then the ability to illegally use something that the federal government is illegal, but can be illegal if prescribed by a legal medication. I just worry about us jumping the gun and creating more of a problem than we're solving.
Thank you. It was a hypothetical question. Representative Javner?
Thank you, Senator Claxton. I am in complete agreement with Representative Perry. I think we have all seen very clearly what has happened with our marijuana policies. The municipalities are asking us not to move forward with this. And especially from my perspective in my district with the UTs, I have so many UTs, they are certainly not prepared for this. So this working group, any hypotheticals, we're not ready. Thank you.
Thank you. I'm not seeing a lot of other comments. Not seeing any other comments. Is your hand still up, Representative Javner, or again?
No, thank you. I'd like to make a motion.
Very well.
I would make a motion to ought not to pass on LD 1582.
Now,
I second
second
that.
motion.
There were multiple seconds. Senator Moore's screen lit up first, so we'll go with Senator Moore seconding Representative Javner's motion ought not to pass. Is there any further discussion? Not seeing any. I'll turn it over to Karen for the vote on an ought not to pass motion on LD 1582.
Thank you, Chair. Representative Zager.
No.
Representative Zager, no. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Can you read the motion again, please?
The motion on the table is that LD 1582 ought not to pass.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry, yes. Representative Javner. Yes. Representative Javner, yes. Representative Madigan.
No.
Representative Madigan, no. Representative Craven.
Yes.
Representative Craven, yes. Representative Connor. Representative Connor is absent. Representative Griffin.
Yes.
Representative Griffin, yes. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
No.
Senator Claxton, no.
So that's
Thank
8 yeses, 4 noes, and 2 absent. Is that right? No, that's not right. What's,
I have
what's the-
eight yeses, 3 noes, 2 absent.
Okay. Thank you. So
Thank you.
the motion does not pass, or the motion does pass as it ought not to pass. And the other folks have a couple days to vote. So Senator Bailey, not what you were looking for. Start of a conversation. A lot of work went into it, I could tell. So thank you for that. And thank you for bringing it forward. I see a comment from Representative Javner.
Excuse me, Senator, not a comment, but is there a minority report you guys want to put forward?
Oh, yeah. Okay. Yeah. Representative Zager, you went first. You want a minority report?
Yes, Senator. Thank you, Representative Javner. I would be, my report would be ought to pass as amended, and the amendment would be a panel. It's still actually an advisory board on the long-term strategic planning for the implementation of psychedelic medications, which would parenthetically include psilocybin as well as MDMA and any other psychedelics. My thinking is that there are medicines that are FDA approved, but the implementation of them requires some thought. Our legislature put a lot of thought into the Death with Dignity Act. Those were all implementing the use of medicines that are FDA approved, but in a manner that we felt were fitting in our state. And so I think that that sort of strategic planning might be useful. So that's why I would encourage that to be the amendment. So it's essentially a very much a narrowing down in the scope of the bill and the ought to pass as amendment.
Are you comfortable with that, Representative Madigan, as the minority report? Okay. Thank you, Representative Javner. So to come back to Senator Bailey, not what you wanted, but lots of work and a start of a conversation and some interest in a council. So people will start thinking about it.
Thank you.
Sam.
Just wanted to ask the folks in the minority report, would it be okay if I worked with Representative Bailey to see what draft she has and then run it by the folks on the minority report? And is that
within the parameters of what Representative Zager outlined? Yep.
Thank you.
Okay. So we've been asked to put 1909 last, so we can move to consideration. So that'll conclude the work session on LD 1582. Next, we'll move to the consideration of LD 1729 and the production of insulin in Maine.
Go ahead and share my screen again. Are you seeing my bill analysis there?
We are.
Okay, it looked a little funny on my end, so just wanted to check. All right, this is LD 1729, resolved to assess the feasibility of the production of insulin in Maine. This resolve requires DHHS to convene a commission consisting of representatives of other agencies or entities and interested groups to assess the feasibility of having a humane system and other appropriate institutions for a public-private partnership between the University of Maine system, other institutions, and a licensed drug manufacturer produce insulin in the state and provide such insulin at reduced, low, or no cost to low-income residents of the state. The resolve requires the Commission to assess the feasibility of such a program by reviewing factors including potential savings and additional costs to the humane system in the state, the number of individuals who would benefit, potential regulatory or legal obstacles, available alternatives, and to seek input from members of the legislature in making its assessment. It requires the Commission to provide a report to this committee by January 1st, 2022, and authorizes the committee to introduce legislation based on the report during the second regular session. Issues from testimony: a number of commenters testified about the expense of insulin and the dangers of insulin rationing. A number of commenters noted the increase in the price of insulin over the past decade. The Maine CDC noted that the cost for treatment remains a barrier for many people in Maine with diabetes. And the CDC also noted that there will be significant research required to carry out this proposal, and that the CDC currently lacks the capacity to carry out that work. The sponsor has proposed some amendments, adding to the feasibility assessment a number of requirements. So we're studying options for copays, capping copays, potential for the state to engage in volume purchasing of insulin at reduced costs, opportunities to engage in an interstate compact with other New England states, opportunities to establish a public entity to manage insulin purchasing and distribution, with the possibility of eventual transition to a privately funded entity, opportunities to establish a model facilities to manufacture and supply insulin, and opportunities to procure dedicated funding to support the manufacture and distribution of insulin. There is also some unallocated language suggested, which was resolved that the legislature shall send a letter to CMS and the FDA expressing support for a federal pilot program focused on the domestic manufacture and distribution of low-cost insulin. And then finally, changing the language requiring the introduction of legislation by the committee from the second session of the 130th to the first session of the 131st. A couple notes. Last session, the legislature did pass LD 2096, which is an act to save lives by capping the out-of-pocket cost of certain medication. As finally passed, that bill provided that a carrier, that is a health insurance carrier, that provides coverage for prescription insulin may not impose deductible copayment, coinsurance, or other cost sharing on an enrollee that results in an out-of-pocket cost that exceeds $35 per prescription for a 30-day supply of covered prescription insulin drugs, regardless of the amount that the individual needs to fill their prescription. The committee did request a couple of research citations that were provided by Dr. Alvarado. Those citations are here with links to the articles for your review. Information on other states' efforts on local insulin production was requested. So it looks like the state that is doing the most in this area right now is California. So they are currently taking steps towards partnering with manufacturers. Senate Bill 852 was signed into law in 2020, and it required their Health and Human Services Agency to enter into partnerships to increase access to affordable drugs, and specifically for insulin. I included a press release from their Health and Human Services Agency talking about some of that work. A couple links here. There's this article about the California insulin pricing. It was pretty clearly written. It was just a kind of a good kind of quick primer on insulin pricing, as well as the Open Insulin Foundation, which was mentioned a couple times throughout testimony, that is working on these issues nationwide. So a link to that organization. And that is what I've got for you. I'll stop sharing.
Thank you, Sam. Are there questions of that analysis? I don't see Senator Stewart in the waiting room or the attendee list. I would have brought him in. Representative Perry.
Yes, Sam, could you go back over the amendments that were proposed?
Sure, I'll put this back up.
If I could quickly interject, Senator.
Please.
Senator Stewart is in class, but he will try and hop over to the committee if you really want to hear from him. He would just need a little lead time on that.
Sure. Thank you for that. Thanks for jumping in. Go ahead, Sam.
So the amendments are to add some duties to the feasibility assessment that the commission would carry out. So this kind of increases the kind of the scope of their work. So it adds these things, numbers 8 through 13, that the commission would look at. So they look at capping copays, and some of that work has already been done through legislation.
Let's leave that up. Let's leave that up and see what Representative Perry's question is.
I guess I had a couple of questions around this. You know, this is really significant work, and I think it's work that we really should do. With the added stuff, it also brings a look at the possibility of finding funding elsewhere, which I think is a piece that needs to go to share that with. I would love to see something move forward in Maine. I think it does two things. It offers the possibility of creating a situation where insulin prices can be controlled. But the other possibility is it could add business that I could see growing if we could establish something as a beginning. And so I guess I'm sort of trying to sell this a bit, but I really think it offers an opportunity for us to actually try to move forward, not just to solve one problem, but also to look at what could come of that when we look at it economically as well.
Thank you. Before you change the screens, Sam, are you saying in that section 2, item number 8, that we already have that covered with LD 2096 from last session?
I think that largely we do.
Yeah, that was my sense. Okay. Representative Perry, did you have any other questions with the list still up? Okay. Representative Javner?
Thank you, Senator Claxton. I'm in complete support of this. I think this is super important for the state, for our friends and neighbors that suffer with these situations every single day with insulin shortages and the costs of insulin. Sam, I apologize. I do have one question for up at the very top. There was a date. It said January 1st, 2022. Is that would just need to be changed, right?
That would need to be pushed forward. Yeah.
Yeah. Thank you.
How do folks feel about the federal pilot portion of the amendment? Add section 4, support for pilot. Anybody who can't live with that? We'll do it that way. Okay. And the language changes on the next one would fall in with what Representative Javner just mentioned. Okay. Thank you, Sam. You go back to out of screen sharing. Are there other questions related to this bill at this point? I'm not seeing any. Senator Moore.
Thank you, Senator Claxton. I just was noticing that Molly Bogart is also in the panel, and I didn't know if maybe she had a comment to make about the bill or about the pilot, or if there was anything that she would like to offer on behalf of the department.
We'll invite Molly to chip in if she'd like.
Sorry, I'm Molly Bogart, Director of Government Relations for DHHS, and I really don't here to be helpful if I can be, but appreciate the opportunity.
Thanks for being here. I'm not seeing any other questions. I see a hand up. Is your hand up again, Senator Moore?
Yes, it is, Senator Claxton. I was going to go ahead and make a motion of ought to pass as amended on Bill LD 1729.
I would second that.
So it's been moved by Senator Moore, seconded by Representative Meyer. The amendments being to add the expanded feasibility stipulations from Senator Stewart, a letter about a federal pilot, and a couple of cleanups on dates and timing. Am I missing anything? Representative Javner?
I apologize, Senator Claxton. However, Senator Stewart is texting and just mentioning that there was a piece of the definition of insulin in his written testimony that he had written about that needed to be changed, analog. So if we could just make sure we note those from his testimony as well. And yeah, his written testimony. I don't know if we can pull that up. I don't know if that's a possibility, or just when we write the amendment, Sam, I think maybe that'll work. We can.
I will find it and I will make sure to include that and run that by him.
Perfect. Thank you so much.
So that's an additional part of the amendment. Any other discussion? I don't see any hands up, so we will defer to Karen for counting the vote on LD 1729. The motion is ought to pass as amended.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry, yes. Representative Javner. Yes. Representative Javner, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Connor. Representative Connor is absent. Representative Griffin.
Yes.
Representative Griffin, yes. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. Thank
So that's unanimous of those present. And there's no minority report, I remember this time. And that'll conclude the work session on LD 1729. If you're texting with Senator Stewart, you might mention that Sam will be looking for him to make sure the language is right. Okay. So that leads us to proceed to LD 1909.
The screen one more time. All right. This is LD 1909. This is an act to remove restrictions on syringe service programs. This bill prohibits a hypodermic apparatus exchange program from limiting distribution of hypodermic apparatuses to program participants or requiring the exchange of used hypodermic apparatuses. This bill does have an emergency preamble. Issues from testimony, the sponsor has proposed an amendment. I have that a little bit further down and we'll pull that up. The number of commenters noted that the emergency order allowing unlimited needle exchanges was very helpful, but that it expired when the COVID-related state of emergency was lifted. The Maine Sheriff's Association expressed concern over the potential for increased needle litter. A number of commenters noted that people who inject drugs may use many needles per day and expressed concern that a limit can be problematic, as individuals would need to visit a syringe services program very frequently to get clean equipment. The governor's office testified in support of establishing a limit on the number of syringes provided per visit in order to encourage program participants to visit program sites to receive harm reduction services and products such as naloxone and fentanyl test strips, and to encourage safe disposal. So current, what I've done here is I've listed current statute, the original bill, and then the proposed amendment so you can compare them. So current statute has language in Title 22, Section 1341 regarding hypodermic apparatus exchange programs, requires that CDC, it states CDC may not limit the number of hypodermic apparatuses provided by the program to participants, but it doesn't have language about a one-to-one exchange requirement. The original bill changes that language to say that a hypodermic apparatus exchange program may not limit the number of hypodermic apparatuses given to participants of the program at any time, or require the return of used hypodermic apparatus as a condition for receiving a hypodermic apparatus. So that is the needs-based approach in the original bill. The proposed amendment would change the current language to state that CDC may limit the number of hypodermic apparatuses and makes clear that rules are routine technical rules. I don't know that that language or about routine technical rules is necessarily needed, because that language is later in the section, so it may be redundant. There was some information requested by the committee. That information was requested regarding the potential for increased needle litter related to the implementation of needs-based SSPs. In other words, does a needs-based approach result in increased needle litter? The CDC did have some information about that. I included a link. They have a fact sheet that stated that SSPs with a needle-based approach to syringe delivery do not increase syringe litter. I did dig down the citations to research, and they did have peer-reviewed research supporting that statement. Information regarding the SSPs in other jurisdictions was requested. So last night when I sent you the documents for today, I included 2 very comprehensive reviews that were prepared by Marcus Peterson, who is a 3rd-year law student intern in Gordon Smith's office. So the first document he has a full 50-state review of SSP laws, and the second one is a further review of New England laws. And he was looking at whether any of them had one-to-one requirements in their statute, and none of them do. It looks like Connecticut might have some rules to that extent, but largely its statute is silent. Some further information for you, the rules themselves, there's a link to them here. That executive order that was referenced a number of times that lifted the one-to-one requirements during the state of emergency is listed for your review. The Syringe Services 2021 annual report, which was just released, is linked there. A US CDC Syringe Services fact sheet is linked. That needs-based distribution and syringe services program fact sheet. And then finally, a list of syringe service providers in the state is linked. So the preliminary fiscal impact statement indicates no fiscal impact. And then this is just the full amendment for your review. It's the same thing as further up, just kind of all laid out so you can see it all together. And that's what I have for you.
So thank you for laying it out that way. As I understand what you just said, that if we don't do anything, then the current arrangement stays in place. And the CDC may not limit the number of apparatuses provided.
Yes, correct.
Do I read that right? Okay. All right. Thank you. Are there other questions? I've been looking for the sponsor, but she's not here yet. Oh, there you are. How did you get in here? I didn't see you coming in. Welcome. Any response to that analysis?
That was very accurate. I don't have anything to add. Thank you for that summary.
Thank you. Are there questions of the sponsor or Sam for right now? I see one from Representative Javner.
Thank you, Senator Claxton. I just am wondering, Sam, did we hear from the Sheriff's Association whether or not they were opposed to the amendment?
I don't know that they spoke specifically to the amendment. They were opposed to the original bill, but I'm not entirely sure about the amendment.
That would have been a subsequent communication because the sheriff was going to do some reading and catch up based on some things that were shared during the hearing. So that would be after the hearing correspondence. Representative Perry?
Thank you. With all the reading aside, I'm just going to give you a personal reason why I will vote for this. In 2000, I had a number of patients who were in their 20s who came in with hepatitis C. And I said, something's going on here. I called the Maine CDC. And what I found out from the Maine CDC is that between 1998 and 1999, the hepatitis C cases tripled, more than tripled in 1 year because of substance abuse issues, the sharing of needles. The ability to get the needles out of circulation is what these programs do. And originally, when we were talking about this, there were just 6 programs. Looking back, there are now 11 programs. And what we need is the ability to get those needles off the street. If we have nothing to get those needles back to, then we will be seeing, unfortunately, a lot more hepatitis C and other types of illnesses, and getting some of those needles off the grounds. Let's expand how we can get those needles back, have clean needles, so we're not dealing with the hepatitis C epidemic and AIDS epidemic and things moving on with that. Thank you.
Thank you for that. Okay. I see that Gordon Smith is here. Did you want to comment at all, sir, since you're a major player in this discussion?
Thank you, Senator. I'm only going to comment because you made a remark a minute ago, and I want to make sure that people are not confused by it. I think you had said that if you do nothing, you don't pass the bill, don't pass the amendment. If you do nothing, that the CDC would not be able to pass put a limit on. But and that's technically true, but the way they put a limit on now is by the rule that requires that you only get 1 syringe for every syringe that you bring in. So in some cases that might be 300, but I mentioned to you in my testimony, I think that the average number of syringes exchanged at a visit last year in the report that's now been, and I apologize, you've only had the report a day or two, was 99. So there's about 100 is about average. So I just didn't want people to think that if you did nothing, that the CDC would have no ability to put a cap on. The CDC intends to leave the law alone and not do further rulemaking unless you pass this bill. And then they intend to do more than the 1-to-1. And they frankly expect to propose a rule that people could then comment on that would establish a limit of 100. So the impact, I think, would be you would be able to acquire 100 syringes or what you bring back, whichever is greater. And this is the result of lots of discussion, and you heard a lot of discussion. So that I just wanted it's a very important bill, a very important amendment. So I just want to make sure that you had that information. Thanks.
Thank you for that. I just didn't want to go backwards because some really good work has been done. Representative Perry, you're all set. Representative Meyer.
Thank you, Mr. Chair. I wonder if there's been any consideration of establishing a floor in rules of 100 to ensure that we're meeting realistic usage needs, adequate syringe coverage. So the rule then would read a cap established in rules of no less than 100.
Is that being addressed to Representative McDonald or myself, or?
I think it is I think I'm asking the bill's sponsor her thoughts.
Thank you, Chair. That has not been proposed, but it's certainly an idea that I would entertain and support.
Gordon, did you have a response to that?
Well, it had not been considered, a floor had not been considered, Representative Meyer, until about 3 hours ago. And I've not been able to get a definitive answer during that time as to the position of the governor's office on that approach. So, I mean, I wish I could tell you that we'd be fine with it. I just don't, I can get an answer. I don't think is Molly with us right now?
She is with us.
So Molly, we don't have an answer for that, do we, right now? No.
No, not yet.
But I have proposed a question, so I mean, no, I just don't have an answer yet. I'd be happy to get you an answer just as soon as I can.
Okay. Thank you for that. Representative Zager?
Thank you, Senator. I'm just trying to make sure I understand. I hadn't heard about the concept of having a floor. I want to make sure I understand. Is that an SSP must distribute 100 or more, or at least a certain number or more to a client, or does that mean that the rulemaking, when it establishes the level, must be no lower than whatever this level would be, 100 or so?
That.
The second, okay.
The latter.
Thank you.
Representative Perry?
Yeah, I'm looking at that. Does the bill allow the department to make that decision? Or because I just hesitate throwing numbers out without the kind of vetting and research that needs to happen. I know we're great at throwing numbers out, but does the bill preclude the ability for the department or whoever's doing the rulemaking to be able to set the lowest limit?
Sam certainly gets to weigh in here. The bill, the amendment does not preclude the CDC in its rulemaking from establishing whatever the limit they want to put out. I'm suggesting you that this CDC is pretty much intends to put out the rule at 100. It doesn't. They would have authority. They have authority. The law would give them authority to establish any limit that they want. And what I understand Representative Meyer is concerned with is that she would not want them to propose a limit or any future CDC to impose a limit less than 100. So that, I hope that answers your question, Representative Perry.
But in another administration, it could be less than 100 unless we put the floor in.
Yes.
Representative McDonald, I see that Sheriff King is on the way. Was there something else that you wanted to say?
It'll actually be Sheriff Nichols, and I just wanted to call the committee's attention to that. So one
Okay.
of them should be here shortly.
All right. Any other current thoughts related to this discussion? Yes, Senator Moore.
Yes, I would. Thank you, Senator Claxton. I just throw back out there, and I know I mentioned a lot of this in my testimony. I am in support of this bill, and I know that during the emergency order when it was there, it worked so well. And even in looking at the stats that were in the syringe report itself, the numbers of people that we reached, I know in Washington County or throughout the state, and actually was able to give them the referrals to service, such as it says primary care, STD clinics, HIV, hepatitis testing, substance use treatment. There was just so much harm reduction, but that was our key point. That was the point we were able to get to them when we had no SSPs open, that we weren't able to do that. And so we were able to save a lot of lives during the pandemic because of that. We're looking here, they distributed Narcan to 1,492 individuals. So this bill, I think, is very important. I love this discussion about, do we set a floor? Because I know that when we do our rulemaking, we open it up to stakeholders, we open it up to the public, we ask for input. And I feel very confident that department will take all those into consideration when they are developing the rules to make sure that this is done correctly. But we have to do more than just the one-on-one. We've got to take it further for harm reduction in this very serious situation that we're under here in the state of Maine. Thank you, Senator Claxton.
Yes, Representative Jevner.
I apologize, Senator Claxton. Is the sheriff representative here yet? I
No,
don't see him on my screen. Okay. I'm obviously, you can tell I'm very interested in hearing what they have to say. But however, I will just say that 631 Mainers, lost their lives. And that's a lot. And I am all about harm reduction. I agree with everything that everybody has said here. I know that this program has worked. I know that, Director Smith has been doing amazing work with the programs that are out there and what we have. I really want to see the efforts be put into treatment. I really think that treatment is such a huge piece of the process for keeping people alive. I think that a needle exchange is working. I think that we all agree on that. I'm not there to think that expanding it to, the expansion of what we're talking about here is going to be that key piece so that 631 number decreases. So I'm just not sure that.
So let's go to, before we go to Representative Levelin, let's just plan on taking a 5-minute break after we hear from him. And we can have also a brief conversation about the emergency preamble. Representative Levelin.
Thank you, Senator. I agree with Representative Javner. I have issue here. I don't have issue with the premise that providing clean equipment solves additional issues of hepatitis, et cetera. Full agreement, great theory. The problem is, I see this as we're helping people with drug issues do drugs more than we're doing anything else. I want to see, I think Maine's becoming a very drug dependent state. It's just my opinion. And I would rather spend money helping these people become away from drug dependency. And what they're doing is illegal, and we're promoting it so that they can do it safely rather than unsafely. Are we going to help all criminals do what they do safely? And if we're not, then this is an unfair bill. Do we have to help these people in some way? Yes, but I definitely think the answer is trying to get rid of the problem and getting these people to help where they'll stay off the drug and not be dependent on it. Thank you for letting me share my opinion.
Thank you. So can we briefly consider the emergency preamble and whether that makes sense to keep or strip out? Representative McDonald, do you have a thought about that?
I do, and that I think that it is important to implement these changes as soon as possible. I mean, 2022 is already well underway, and we are still facing a deadly opioid crisis.
Mm-hmm.
The sooner we pass this, the sooner they could initiate rulemaking.
Okay. Any other thoughts about the preamble? I suppose it all. Go ahead.
I've got a thought. I would and again, it's based on what I've heard from your discussion, I would probably remove it. And the reason is that the rulemaking process, we could prepare the rule. It is a short, we pray that it will be a short session. So the effective date won't be, in the fall. And I think my point is that it complicates the process if it doesn't look like we're going to be able to achieve a 2/3 vote, then I would just as soon have it considered, have an effective date 90 days after the session and make sure that on that day we have the rule ready to publish. The way things are going with COVID and rules and things, it takes a bit of time. It's got to go to the AG's office and then back. So I agree with Representative McDonald, and I'm not happy to suggest that probably you should take the emergency off, because absolutely I wish we could do this today. But I think realistically, it's going to probably take, by the time we get the rule done and be able to effectuate this decision with the 18 sites, it won't make that much difference.
Representative Meyer?
I thank you, Mr. Chair. I would agree with Director Smith.
In terms of stripping out the emergency clause.
Correct.
Yep. Representative Javner?
Thank you, Senator Claxton. Director Smith, I would just perhaps mention one thing, even, that it is very, if the sponsor wants to keep the emergency and she feels very strongly about that, it is an easy process to strip the emergency on the floor when it goes to the vote. It's very quick.
Thank you for that, Representative Javner. Representative McDonald?
I'm happy to go either way. I'm not, intimidated by making a floor amendment on the floor, but if members feel that it's easier to strip it, it's fine.
Okay, thank you for that. I'm not seeing anybody who looks sheriffy in our attendees list. So why don't we take a 5-minute break, give them some additional time to get here, and come back at 2:21. And that'll save Representative Griffin from reminding me that we've been sitting for a while. All right, we'll be back at 2:21 and see if we've had a sheriff been able to join us. So I think we can resume our deliberations. I'm not seeing anyone representing the sheriff's group. I have a question for Representative Javner when she comes back on. While we wait for that, do we have any other questions or concerns? Anything you want to bring up related to this? Unresolved at this point is the issue of Representative Javner's concern about needles and the emergency clause and a floor of 100. So Representative Javner, my question to you was, would it make a significant difference to you to learn from the sheriff that they had done some reading and they weren't as concerned as they were? Would that put you in a different position in terms of voting? And you don't have to answer that if you don't want, but I'm just trying to understand how to, whether we
Sure,
should.
I'll answer that. No problem whatsoever, Senator Claxton. Thank you. You know what, to be perfectly honest, I don't think so.
Okay.
I really do want to hear back from them, but it's not worth putting this bill off. I don't believe so. We can,
And that was the question behind the question. So thank you for that. Appreciate that. Representative Meyer?
Thank you, Mr. Chair. My suggestion about a floor here was simply that, something to consider. I hear Director Smith's concerns, and so I certainly could support the amendment as Representative McDonald brought it to us. However, I would still recommend we strip the emergency.
Is that a motion?
I would say that it is, yes.
Okay.
I'll second that.
So there's been a motion ought to pass as amended, the amendment being the new amendment from the sponsor and removing the emergency clause. Is that what your intent was? So moved by Representative Meyer and seconded by Representative Craven. Any discussion of that? Yes, Representative Zager.
Thank you, Mr. Chair. What about the floor that was brought up? Is that part of the amendment that is now being considered? No. Okay. Thank you.
Okay, I'm not seeing any other discussion, so we can turn the voting on LD 1909 over to Karen. The motion is ought to pass as amended. The amendments are to remove the emergency clause and to adopt the amendment proposed by the sponsor.
thank you, Mr. Chair. Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
No.
Representative Lemlin, no. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry, yes. Representative Javner.
No.
Representative Javner, no. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Connor. Representative Connor is absent. Representative Griffin.
No.
Representative Griffin, no. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes.
So the motion ought to pass as amended carries. And we'll look for minority report.
Thank you, Senator Claxton. I think just as of right now, it'll be on not to pass. Thank you.
Thank you.
Thank you for your time. Bye, everyone.
Thank you, Representative McDonald. So that's 8-3 with 2 absent. That will conclude our work session and vote on LD 1909. Following this morning's session, we've initiated the process of putting out the 2 bills related to PTP. That's just an update. Things are moving faster at this point. Pretty soon we'll be able to, when we go to the scheduling, be able to schedule a week ahead instead of the 2 weeks, because of where we are in the calendar. We as a group are doing pretty well. We don't have all that many more bills that we have to hear originally. So thank you all for that. Any other business to come before the committee before we adjourn for chairs and leads and scheduling? I'm not seeing any, so I'd entertain a motion to adjourn.
So moved.
Second.
Moved and seconded by a lot of people. All those in favor of adjourning until tomorrow. Thank you all for the good work. Thank you for being here, Mr. Smith and Molly.